Can you hear me, Morgan? Okay, perfect. Let's get a shot of her on this side. See what it looks like. From her mic, sorry. Let's go to where she'll be. Oh, she won't be standing at that mic.
Good afternoon, everybody. Do you hear us? Yes? Okay, fine. Welcome, everybody, to this session on palliative care. I'm Caroline Verlinde. I'm from the Flemish Institute of Primary Care in Flanders, and I have a co-chair with me.
Yes, hello, everybody. My name is Charlotte Klinge, and I'm from the Karolinska Institutet in Sweden.
We like to make the session interactive, though with 6 speakers, that's not going to be very easy. So we would really like you to use the app. If you go to this session, you have a Q&A, and so you can ask your questions, and you can also vote on each other's questions. So then we know which question really needs to be asked. So we really would like to encourage to use the app. We have 6 speakers. We're going to let them give their presentation. And at the end of all 6, then we're going to pick out the questions which are most voted by the public here. But there's also a virtual audience following us, and we would like to encourage them as well to ask their questions in the app as well.
Yeah, and I will go around with the mic, so those of you who have asked a question will have to wait until you get the microphone so that everyone hears the questions.
Indeed. Now we're going to start with the first speaker, which is Anneleen Craps. She is from the Flemish Institute of Health and Care. Soon, in 2 weeks' time, is going to be the Department of Care. And she's going to tell you about the reform on palliative care in Flanders. Anneleen, the floor is yours.
Thank you. Good afternoon, everybody. Is the mic on? Yes. Okay. Let's see, okay. Caroline was so kind to introduce me, so I'll skip this slide. So, the reform of the palliative care in Flanders. I would like to explain to you all what we are doing and why we are doing it. We all know that palliative care is, in its essence, person-centered care. We take into account the care, the needs of the patient, the person, and his loved ones, and we are focusing us in organization to give the care and support that this patient needs. At this moment, and that's because of the history, palliative care at the moment is not financed, does not have the governance or the organization to support that, to value this. So we as a Flemish government, we have the ambition to reorganize and to reform this palliative care. Our ultimate goal is to make it qualitative, accessible, and goal-oriented palliative care. What does this mean? Palliative care is for us in the to-be, in the future. It already is now, but in the future it is valued for it. Person-centered care, as I explained, but also is accessible, and citizens, professionals are aware of what palliative care is, because palliative care is not end-of-life care, not only end-of-life care. So we have to make sure that this palliative care is taking up in the pathways, in the care of the person that needs it. Accessible for everyone, the patients that really need it, the persons that really need it, but also the hard-to-reach target groups, because sometimes they don't get the care, the support that they need, that they want. Care and support needs, that's a very important thing for us in Flanders. We base around what the person wants, what their goals are, and in this sense, what the end of life needs and goals are from this person. We are developing a digital care and support plan. That's a tool where these needs, these goals can be documented and where the care and support is organized too. The continuity of care, also this is seamless care. If you have palliative care at home or in a hospital or wherever you need, it has to be seamless, it has to be coordinated. If so, we have case management to support the team. and there are sufficient caregivers. Now this last thing, it was a very important question from our focus groups. I will explain to you later. But also in Flanders, we have shortage in these professionals. In everything we do, there is attention for the informal caregivers, the loved ones, the family of this person, because in palliative care, there is a big amount of support that is given by this informal caregiver. So we have to take that into account in what we are organizing financing. We are not doing this top-down. We as a government, we are not doing this alone. We are doing this with a lot of stakeholders. And the stakeholders is primary care, but also the specialized care, retirement homes, representatives of patients and informal caregivers. They helped us to make a clear vision on what this to be of palliative care should be. I showed you the previous slide. This is what we need in palliative care, and this is what we made together with our stakeholders. It must be a well understood vision for all these professionals, but also the informal care. The plan that we are going to develop within this vision is a realistic plan to go from what we do now to this to be palliative care. We have a few points that are very important in this reorganization. That's a smooth transition. We cannot expect that we do a complete reorganization overnight. So we have to empower, coach this primary care to take up this palliative care. We have expertise. We have networks in palliative care with a lot of expertise who can support, coach, and support this primary care. A second focal point is that this primary care can do this, because it's not our ambition that palliative care is another care and support on top of everything else they do. No, palliative care is a part of the plan, that the care and support plan that they already do for these patients. For that, and that's also in the plenary session that it was a very important thing, we have organizations that can take up this palliative care. We have an ecosystem that knows who does what, who in the network can take up certain tasks or has certain roles within palliative care. So we have to make sure that it's very clear what these roles, responsibilities are, how these ecosystems work, and for that we need processes. We are working around systems of collaboration, networks for this palliative care. The palliative care cannot just be implemented. Everybody knows something, but no one is expert in all. So we have to educate people to know what they can do within their roles and responsibilities. But it's also important that it is in the education of every professional, care or social care, whatever. They have to know the basics of palliative care. Also, that is important to elevate the level of comprehension. Tools and data to support. I already mentioned the digital care and health plan that we are developing, but also tools to make sure that there is population management, knowing what people are in your region and what needs they have around specifically palliative care. We as a Flemish government have the ambition then to have a correct financial regulation for these networks. To make sure that we are achieving our goal, we have two groups to listen to. First and foremost, it's the citizen themselves. We are doing it for them, that it's qualitative, that it's accessible, what I said. So to make sure that their needs, their questions are answered, we are organizing group sessions, focus groups with them to really do a body check. Is this organization, is this offer of palliative care, does it answer your needs? We also have a scientific research, an impact analysis that is asked for to really evaluate this reorganization. Do we achieve what we want to achieve, and do we achieve it in time? Short, our timing. next month, in a few weeks, we are delivering our vision statement. This vision, actually we already have it. You saw the circle, you saw the other slide of what we need in this palliative care. We are going to work this down in a very clear vision. At the end of this year, this vision will be translated in concrete action plan. What do we do to achieve this vision? It's also a transition for the sector, for everyone in the primary care. So we have to make sure that there are clear timing, that there are milestones to achieve. How do we go from as is to be? And as from 2024, next year, we are really going to roll out this reorganization. Voilà, that was my presentation. Do I have? Oh, wow.
You were very well in time. We still have 3 to 4 minutes. So if there are any burning questions, then you can still ask your question here in the room. Not yet.
Not yet?
No burning questions? Yes, there is a burning question, and the mic is coming over. Just a... Yeah.
From the Belgian government. Exactly what's going to change? What is the scope of the reform? What will be changing?
We are changing the way that we all know in Flanders and in Belgium, we know the palliative networks. These are organizations. We have 15 in Flanders. They have their own region. They are experts in palliative care in education. But what we really want to do is make sure that this expertise, this knowledge of palliative care goes broader in the primary care. So professionals in primary care, but also organizations, retirement homes, that they are very known in, very relaxed in taking up palliative care themselves. There's always these palliative networks. We have also equipes, groups of specialized nurses that comes at home to the patients. It's very valuable in Belgium. Also, they exist and they stay there, but it's our ambition that they are more second and third line in the future.
There is another question in the app asking if the government, so the Flemish government, or perhaps also the federal, is considering the implementation of the inter-RAI palliative care in Flanders.
We know that it's important to have a tool to measure and the needs actually also from this palliative care. So yes, it's on our radar, but we don't have a really good action to implement it or not, because there's a lot of questions also for us in case of financing, and a bit of the afraid that if we use this BELRAI or this instrument, that is only for financing, and that's what we don't want in the first place.
Okay, so an instrument, but not directly for financing. Another burning question in the room, yes?
Thank you so much for such an interesting presentation. I just have a follow-up for you. So when you said that you're looking at maybe transmitting the knowledge about the palliative care networks to primary care, is that just about referral to these networks, or is it the knowledge that they already have to be implemented in primary care teams? I'm Canadian, so I'm not totally understanding your system here, so I'm just wanted to understand more.
It's both. There is already expertise in primary care around palliative care. These palliative networks, they would be excellent in coaching and really make sure that it's always better. This palliative care gets better and better over time, because what we do now, it's very good, but we know that the quality can always rise. Okay,
thank you very much. And I think we need to go to the next speaker, who is Louise Dear. She is a PhD student at the VUB in the end-of-life care research group, and she is going to tell us a bit more about 2 neighbourhoods initiatives in Flanders.
Yes, that's right. So my research is on civic engagement initiatives around serious illness, dying and loss in 2 neighbourhoods in Flanders. And today I will present some of the results of this research. Yes, I did this together with a team of researchers from the VUB, from the end-of-life care research group. So these are my colleagues. So compassionate cities and communities actually started already in 1986 when the Ottawa Charter for Health Promotion was signed. That's an international agreement with 5 key principles, and one of the principles being strengthening community action around health promotion. And the man you see there, Professor Kelleher, he was the first one to make the translation from health promotion to palliative care. And compassionate cities, compassionate communities are one such application of a health promotion and palliative care approach. And these compassionate communities are supportive networks for people with serious illness, their caregivers, people who are bereaved, and they can actually be developed in every setting. You can develop them at workplaces, at cultural organizations, but one of the settings is the neighborhoods, and that's the focus of my research. So let me introduce you to the 2 neighborhoods from my research. The first one is in Herzele, the second one in Sint-Kruis. And I myself, I'm kind of a city person, so I tend to call them rural villages, but they are actually semi-urbanized villages if you look it up. So both with a population of around 10,000 people, but the neighborhoods we focused on have a population of around 4,000. And the neighborhoods we chose are actually in a radius of 1.5 kilometers around the city centers. So they consist of most of the organizations, initiatives, local shops, and etc. Both neighborhoods are also have a bit the same challenge of a population of older people and also a kind of larger population living alone. A really quick slide on the methodology of my research. So it's really a mouthful. We did a convergent parallel mixed method process and outcome evaluation, which is actually just a really difficult term to say, that we collected both quantitative and qualitative data simultaneously but separately. And at the last stage of the research, we tried to combine that data through narrative synthesis. We collected a lot of data. We did observations with all the stakeholders in the neighborhoods. We did group discussions with people in the neighborhoods, interviews, document analysis, a most significant change method to determine the impact of the research, and hopefully, if there's still time, an ego network mapping of people in the neighborhood. So that's actually a lot of data. I think now we're at around 150 observations, around 70 interviews, 50 documents we're analyzing, so that's really a pile of data. And at the moment, we're going through the analysis and trying also today to present you with some first results on that. So what characterizes my research is that those neighborhoods, we also call them compassionate neighborhoods, are situated in compassionate cities. And compassionate cities, that's research of my colleague Bert. And the first step in that research was approaching cities. So we did that in 2019. We approached the 2 cities of Bruges. Sint-Kruis, my neighborhood, is a sub-municipality of Bruges. And we selected the city because it really had good motivation to step into the project. It was also confronted with a few challenges. So we decided on Bruges as a first city, and we decided on the facilitators for the project. We had 2 facilitators, one from the city itself, a person within local social policy, and a second facilitator, Ruth, who does the facilitation between VUB and the city. Because my research is situated within the compassionate city, we did a sort of official launch of the compassionate cities, and in the compassionate city, they also subscribe to a charter with a few points in it, but because my neighborhood is a more bottom-up approach, we did not develop such a charter to develop initiatives in the neighborhood. So what I did was actually dive into the neighborhood, start with a soup with chats, where I brought most people in the neighborhood together. We invited citizens, people from different organizations, and asked them about their needs in the neighborhood, which was mainly on having a point where they could address their questions, and also a question for inspiration to develop initiatives around serious illness, death, and loss. And we continued our stakeholder mapping with doing interviews with really broad population in the neighborhood. So we did also interviews with the neighborhood police. We addressed the priest in the neighborhood, local shop owners, owners from cafes, so to really have their point of view. And then you see there goes a lot of time over it. So eventually in September 2022, we started with our Compassionate St. Clair's project, which also coincided with the start of the Caring Neighbourhood project. In Herzele, we did kind of a similar approach. So we selected the city. There was also a more official kickoff for the Compassionate City, but they chose to focus on compassionate schools there. And also for the neighborhoods, we did not have a charter or a first plan for development. So we started again with our soup with chats in the neighborhoods. And they decided to focus, because caregiving was a point they often raised in the neighborhoods, to focus on an initiative that was already there, the caregiving cafes. But until that point, they hadn't reached a lot of people with the caregiving cafes. So now we really started a bit more bottom up and asked people how to develop these caregiving cafes and how to make it interesting for them. I will present you shortly with some key results and recommendations from my research. So first, in terms of stakeholder coalition building and addressing stakeholders in the neighborhoods, we think it's not necessarily a first step to really have a coalition of stakeholders, because in St. Clair's we really started with forming this coalition, with forming this structure, but we saw that in Herzele, we started first with the caregiving cafes, that addressing stakeholders can also be a second or third step in the neighborhood. We also think that thinking outside the usual suspects can be a good thing, because it's good to already have a good collaboration with certain organizations, but we see that there are a lot of other assets in the neighborhoods, such as neighborhood police, such as local merchants. So really to think a bit outside the box as well. This stakeholder coalition building is also sort of a dynamic process. Depending on which initiative you develop, it's good to have a group of people working around that, but it doesn't necessarily have to be the same group over the entire process of the research. And it may seem like a bit of a silly recommendation to have a common theme to work around, but developing a compassionate neighborhood can be sort of abstract or vague sometimes. And it's often mentioned as a common theme already, but it's better to have something within there, such as, for instance, a focus on people wanting to develop a coffee initiative in their neighborhoods and talk about these initiatives. And then it's a lot more specific than just creating a compassionate neighborhood and initiatives. So when developing these initiatives, we try to build on the existing assets in the neighborhoods, such as the caregiving cafes we recommend. We also think that less is more, that in Herzele we only had the caregiving cafes with which we started, but that is actually a very sustainable approach for us. Whereas in St. Clair's we experimented a bit more with different initiatives, but we saw that in the end there's only one initiative now that is really consistently coming together, the initiative on consolation spots in the public space. So less is more. Also connecting people, and if they already have a question, to be connected to others is a good asset and a good facilitator. And again, people should choose their own structures and their own working forms to develop these initiatives, so they shouldn't be very formalized structures. A last recommendation is on the organization culture within the neighborhoods, because we started from 2 cities, that there has to be the same definition of co-creation in the neighborhoods. Co-creation for us as researcher, we started it from a community development approach, like really empowering the community, empowering the neighborhoods to formulate their own responses. But the definition of co-creation within the city was more asking for input from citizens and working together with more formalized stakeholders. So that definition is actually, you should start with at the beginning to try to clear that out. Also sufficient staff and needs, because COVID was a challenging time. There were other priorities in the neighborhoods. And for me, as soon as there was some funding from the Caring Neighbourhood project in Flanders, there were more means to have a community worker, a neighbourhood worker in the neighbourhoods. So that was really a facilitator. Also, if you start from a city, support from the policy group is an important one. If colleagues from the city department can also work across different departments and not stay within local social policy, for instance. So this was in a nutshell my research. So if there are any burning questions.
Yes, there are. Somebody is asking, I don't know whether that person is in the room, Zoe T? Yes, well, she can ask her question live.
I was wondering about the stakeholder mapping and how you were able to define your scope for that, because I imagine there's a broad range of stakeholders you could have included.
Yeah, I think our scope was a bit of a snowball method that we started at more the official and formalized stakeholders, which were also recommended by the city. And we started interviewing them, but also asked them, who do you think the key figures in the neighborhood are? But we also noticed that the city more kind of wanted to play it safe, and that especially in St. Cres, where there was really a formal stakeholder structure and group, that these were actually still the stakeholders that they already knew from the beginning. And that in the development of the initiatives projects, it was more me as a researcher that tried to also involve the other stakeholders as well.
And did that have a valid added value, the fact that you actually also proposed other stakeholders? Do you think? I think because as a researcher you're a bit outside the circle, so to say, so you can observe, and you can through interviews with you're not a city, so people address certain questions to you and certain needs. So I think it was valuable for me, for a researcher, to report that back, but we still found it was a difficult process to also include them in the research, because it's also a way of working already that existed in the neighborhood, of working with these collaborations that were already in place. So I kind of had to remind them each time to do that, but it was not always too successful to actually include them into the project. Okay. Yeah. Any other questions from the room? Yep. Yeah. Wait, so the people at home can hear. Yeah.
Hello, I was cooperating in Bruges, still am, but what now the project and the project finances, and how can you keep things like this alive, or start things like this without project finances and researchers and so on?
Yeah. I think that's a main challenge in compassionate communities and compassionate neighborhoods. What I see now is that the initiatives that still exist or are still running are the ones that kind of develop more bottom-up, so outside the official stakeholder coalition, just people saying, we already have a consolation spot. We have 6 different consolation spots, so troostplekken in the neighborhood, but we actually don't know each other, and it would be nice to organize activities together. And that's really a group with the same motivation that found each other. And I think that helps for sustaining the project. Also in Herzele with the caregiving cafes, because that started more co-creatively with the partners, so that has also a higher chance for succeeding, I think. But I do think that there's still one person you need, I think, to facilitate it. There needs to be always a person to kind of keep it going, and that's a challenge when the funding stops. So, yeah.
Okay, thank you very much. Perhaps Ruth can also give us a view on that, because Ruth is also going to talk about compassionate cities, the 2 same compassionate cities, I understand. Ruth is a palliative network coordinator for more than 20 years already, so she can really talk from out of practice. And she is also very interested in the culture of care and about changing the culture of care. So I'm very curious about your light on this topic.
Okay, thank you, Caroline. So yeah, I will continue to talk about Bruges and Herzele, but then from a project management point of view. So the level above the compassionate community. So actually, I will repeat some information. What we wanted to do is bring palliative care back to the community, because issues of serious illness, dying and grieving are social experiences. We discovered in former research that about 5% of their time, palliative patients are with their formal caregivers, which means that 95% of their time they are with family and friends and colleagues and whatever. So can we foster a community approach that is complementary to the institutional healthcare, improving end-of-life quality was one of the questions. We chose a top-down research project based on the compassionate city idea of Alan Callagher Louise talked about. It's a collaboration between the University of Brussels and I myself, I am the coordinator of one of those 15 platforms, networks of palliative care Anneleen talked about. And I was also one of the transition coaches in the implementation of the primary care zones in Flanders. So our cultural change question was, how can we invite people to think and act differently to realize this social change? I won't explain about Bruges and Herzele, but I will tell, when we approached these cities, they both agreed that the idea of growing solidarity and community care as an answer to social bitterness, coldness, and isolation in both of their towns, that was like a shared vision. So that's why we worked with them. We started like a nice change project should start with a leading coalition. You can read there that the first participants, the city councils, were 2 aldermen and the city director in both cities. When it came to stakeholders, we saw that in Bruges they were mainly the formal organizations, whereas in Herzele we started off with some just like key people in the social network of Herzele, like the priest or some neighbors, some volunteers, also some formal caregivers, but not in the way it was in Bruges. And we saw that the city project leader also had a very different position. In Bruges, she was situated in the team of local social policies, which is actually a policy making and a project implementation team, whereas in Herzele, Vrije is in the local services center, and that is a center like an open house connecting the citizens on the one hand and the caregiving network on the other hand. So much more on an operational level, which had an impact on the projects. We also saw that very quickly the leading coalition changed. Mainly the politicians, they said, well, it all becomes too operational, and they drew out a bit. So we had very quickly, this is about facilitation, we had very quickly to adapt structures. And in Bruges, we evolved to a core team that was like facilitated by the city project leader, with some working groups led by stakeholders themselves. And we saw that these working groups worked very differently. We also saw at a certain moment in time, we had a congress, a PHPCI, a Palliative Care Congress in Bruges in September 22. We saw these work groups shifting towards the preparation of some very specific initiatives in the context of that Notes Festival, which was a citywide festival also for the citizens themselves. And then very quickly after that, it evolved to a learning network, and then the compassionate community Louise talked about. Whereas in Herzele, we took a whole different way. There we split, like we made a policy team there, because the politicians wanted to keep to be involved in a way, one way or another. So we had a policy team there and a project leader team, which was actually the local project leader with Louise, Bert, and myself mainly. And they made the policy team made a political choice to really delimit, because of time reasons, to compassionate schools. We started like with the idea we wanted these schools to co-create, because that was our vision. We thought that that was the right thing to do, but we very quickly had to install school teams, school per school, trust issue, I will talk about that later, and then a compassionate community as well. I will talk to you about the tensions, because I think that's interesting. We had tensions on the stakeholder level. We had a number of people who wanted to create a vision and work a vision and then do things. And we had another group of people who wanted just to do things, assuming that the cultural change would follow. Very difficult to manage. We also saw that the activity of the work groups and the school teams largely depend on the people who are willing to take responsibility and also willing to dedicate time and priority to those working teams or to those project teams, and their personal competences and preferences. Something I like to call the know-like-trust history. We saw that between work groups and schools on the one hand, and the city and the history of working together with the city, that impacted our project, the development of our projects or our actions. Also between stakeholders, the way stakeholders had been interacting with each other and collaborating with each other in the past really had an impact on how the scheme went on. This is a nice one. No one says that palliative care should not be brought back to the community. The intellectual willingness is very huge, but if it comes to a full commitment, putting priorities based on a real sense of urgency, it's a whole different story. And something that was already said today, communities, they don't want to feel accountable to the city. They want to be supported, yes. They want to network with each other, yes. But they don't want to report to the cities. They don't want to be controlled by them. And of course, stakeholders follow for as much and as long as they feel motivated to do so. All tensions we need to facilitate. But also some tensions on the city level. Our choice for a top-down approach had an impact, but also the city culture, which was in both cities mainly a top-down culture, impact the practice of co-creation. The definition Louise told about. The position of the city project leader impacts the leverage she has towards other stakeholders. Louise talked about the police. We saw that police was an important partner in the community, but police, of course, is not part of the local of the social network. So it's a different department. So attention there, where we also link to the silo structures that impact the possibilities of cross-fertilization between departments. All things you have to facilitate. Sponsors expect quick win results, whereas networking is key and very time-consuming and less visible. And it's an answer to the question of you, Veerle. Yeah, we have some real concerns about the sustainability of these projects after the 2024 elections, because we see that it might be rather an alderman's project rather than a city project. So this has to do with the buy-in of that leading coalition. So that's something to reflect upon. And of course, we also had some tensions due to the context. I think our first meeting with Bruges was about 2 weeks before the country went in the first lockdown, so it was a difficult period. Labor market, and then with the Ukrainian war, the financial crisis, it all interfered. So how did we navigate these tensions? Because that's what facilitation is about. It's about navigating these tensions. I realized, looking back, that most of my time was invested in the coaching and the mentoring of the project leaders themselves in their facilitation role. Certainly at the beginning of the process of the project, a lot of facilitation of collaboration between stakeholders. You remember the know, like, trust I talked about, like building trust. Facilitation is a lot about balancing. Balancing between this high-level cultural change goal. We want to have people bringing back this palliative care to the community. It's a high-level goal, and then the need for action. So I invested a lot of time in reframing actions in that higher level to make sure that there is a connection between the operational approach and the vision that we aimed for. Keeping the role of a facilitator is not always an easy role. You are not a consultant. There's no mandate for that, so it's about supporting rather than steering. If you want to steer, it's through the local project leaders, and also balancing this academic input. We had some very enlightened ideas about what to do, but the cities didn't always buy it because they want to have their own context-specific initiatives. And as I told, it's about adapting in a very flexible way the project management systems and structures to those shifting needs. So let me bring this to some learnings and reflections. Compassionate cities and communities develop in a very complex context. It's a people's business. It's about creating like a dream vision that really attracts people towards the same goal, and that has the power to reconcile these long-term social change goals with other priorities and, as we saw very often, the delusions of the day. It's about working with the people as they are, with their own beliefs and conflicting interests, personalities, competencies. It's about working with the dynamics as they are, that know, like, trust factor, the leadership culture within the city, the culture of working together among stakeholders, all those things. It's about management structures and systems that impact possibilities. And I think, last but not least, as a project leader wanting to facilitate this kind of processes really needs maturity, networking, and facilitation skills. So, did we find this one-way quick fix solution for realizing social change? I'm afraid not, but we are working towards a framework. Very briefly, we work in a difficult context. It's about a process of facilitation, doing interventions and seeing what the result is and adapting. It's about people with a vision, human beings, and the culture of leadership and collaboration. And it's about that management shift. We are not working with systems and structures. People don't follow systems and structures. They do things, and they are supported by these systems and structures. I realize this is a very short explanation of a complex model, but there is a poster on the theme if you look in the poster office. And for the Dutch-speaking part of the audience, there is a book coming up on this theme on beginning of 24. Voilà. Thank you.
All right, thank you very much. 2 minutes left. Yes. Who is going to use the 2 minutes? Any questions in the room? Were there any questions in the... No, not in the app about financing, but you also talked about, well, financing and the sustainability of the project. So it was a very complimentary session, so thank you for that. There is a question in the room at the end. Just...
Thank you. We're also trying to build community projects and things like that back in England where we're from, but how did you get the information, the intelligence about how the different groups work together and which groups didn't work well together and which community groups like each other and things like that? How did you go about assimilating all that knowledge?
Using your eyes and your ears. It's as simple as that. But as a facilitator, you really need to focus on what's happening here, not on the content, but on the process of what's happening. And then you see, and then you hear the stories. You have to walk around, you have to be in the network, and then you hear the things, and then you have to have the courage to put this difference in belangen, interests, the conflicting interests, daring to put the conflicts of interest on the table, and that's how we facilitate it. But it takes some courage from a facilitator, hence the importance of the maturity of a project leader.
Okay, and thank you also for the framework, which can guide us all in a changing cultural change. Thank you very much. Kirsten Hermans is a PhD researcher at the University of Leuven, Lucas, the Research and Consultancy Department of Leuven, and she's going to talk to us about the role of hospice care at the end of life.
Well, thank you for the introduction. Well, yes, I'm Kirsten Hermans. I'm a postdoctoral researcher and project leader at Lucas, which is the Center for Care Research and Consultancy of the University of Leuven. And indeed, I will talk to you today about the role of hospice care, or actually also medium care, at the end of life. And I will discuss the experiences of formal as well as informal care professionals, caregivers. So first of all, some background information. We see that most people actually prefer to stay at home when they are getting sick. So most people nearing the end of their lives also prefer to stay at home, and they also prefer to eventually die there. But sometimes dying at home is not possible when care needs are increasing. Because an informal caregiver must be present 24/7. And we see that sometimes there is no informal caregiver, and sometimes the informal caregivers suffers from stress, sleeping problems, and health problems. So as a result, in the terminal phase, many people still end up in the hospital after an emergency admission. But here in Flanders, palliative units, well, there's limited beds available in palliative care units. So people tend to end up in acute hospital wards. 40% of deaths, therefore, still occur in an acute hospital ward. And these acute hospital wards are not specialized in palliative care. There is thus a need for initiatives to provide quality end-of-life care, to reduce these hospitalizations at the end of life, and to also reduce caregiver burden. So in some countries, there is hospice care. Hospices have been established, for instance, in the Netherlands and also in the UK. And hospices are actually care facilities that specialize in palliative care, but they are intended for people who have a life expectancy of less than 3 months and who cannot or do not want to stay at home or in the hospital. Now, what's the difference between palliative care and hospice care? Hospice care is actually a part of palliative care, but hospice care really focuses on these last months of life, where palliative care begins with a diagnosis of a serious illness, for instance, dementia, cancer, COPD, and so on. Palliative care is focused on treating the illness and on providing psychosocial support and spiritual care for the patient, but also for family members. Whereas hospice care is actually focused on comfort care and also on preparing people for the end of life, preparing the patient as well as the family for the end of life. There's no invasive treatments anymore in hospice care. It's really focused on alleviating the symptoms, the physical symptoms, and also providing spiritual, psychosocial support. So in Flanders, there's 2 nursing homes who set up 2 hospice initiatives within the walls of the nursing homes. There's Sint Vincentius in Avelgem and Huize Nazareth in Tiene. So in order to expand this offer and also to optimize hospice care, we needed some extra empirical data on the added value of these hospices and also on the bottlenecks. So the aim of our study was to identify the hospice care experiences of care professionals and relatives of people nearing the end of their lives. And this study was financed by the Koning Boudewijn Stichting. We conducted 2 focus groups with 17 care professionals and 10 interviews with relatives of people who died in the past year. And then we identified the characteristics, first of all, of the hospice residents in the nursing homes, but also the added value and the bottlenecks, as well as we formulated also recommendations for the future. Now, what are the characteristics of the hospice residents in nursing homes? These hospices are actually intended for elderly people who live at home, but who come directly from the home situation or after an emergency admission and stay in a hospital ward, an acute hospital ward. We see that there is an acute deterioration in their health condition. They're also in the terminal phase, and this evaluation is based on results of the PICT, the PPS, and also the physician's evaluation. And these people do not need any invasive treatments anymore. So this slide provides an overview of the added value and also of the bottlenecks. I will now go into all these factors one by one, but very quickly because there's not a lot of time. So first of all, care professionals as well as relatives mentioned the quiet atmosphere in the hospices. So there's less agitation and less crowding than there is in a home setting or in a hospital, and there's also no more unnecessary treatments. For instance, they don't take people's blood pressure anymore like they do in a hospital. And the care team is much smaller. The relatives also mentioned the home-like feeling. So hospices are furnished very home-like. The atmosphere is very personal and familial, and relatives are welcome day and night. There's also couple rooms available. And then there is the closeness, and this was mentioned several times also by the care professionals. There is this geographical closeness. So first of all, people can stay in their own region or the region where their loved ones are living. So it makes it much more easy for relatives to visit them. And on the other hand, they say there's always someone present. Because hospices make use of volunteers a lot. And this is very important for people nearing the end of their lives because they feel less anxious when they're not alone. A lot of people are afraid to die alone, so these volunteers are really a big plus. There's a lot of support for the informal caregiver in the hospices. They say they can hand over a lot of tasks, much more than they can do in a hospital or at home. And they say they can be a spouse again, a son or daughter again, a brother or sister again. The care team is quite small in a hospice. There's a close collaboration, and the care team is very interdisciplinary. But something that was mentioned several times is the fact that there is a very strong involvement of the family physician in the hospices. People can really bring their own physician with them to the hospice. And again, the volunteers were mentioned as a great added value. In hospices, there is an open and transparent communication. There's a lot of conversations also with the family physician, and there's many multidisciplinary consultations in a short period of time. So people only usually stay 25 days, and during this time there's a lot of multidisciplinary consultations with the relatives, but also with the resident or the patient. Care professionals also mentioned the intensity. Again, the mean length of stay is 25 days, and the care is really focused on the end of life. Whereas in a nursing home, the care for the residents is not only focused on the end of life. Care professionals there build trust in a very short period of time and have multiple in-depth conversations. And then last but not least, the quality of death and aftercare was also mentioned as an added value. In hospices, there is a strong involvement of the care professionals. And what we also see is that partners can still stay in the hospice until after the funeral or cremation. But there's also some bottlenecks. First of all, currently there is no recognition or financing of these hospices. So these initiatives really rely on the goodwill of the care professionals, and there's no extra resources for training, for hiring extra staff, and it's not possible to expand the initiatives. Again, something about these staff shortages. We see that many visitors come after 5 p.m. So in the evening, it's sometimes hard to answer all of their questions, and there's not a lot of care staff in the evening. And also at night, when people are feeling anxious, it would be much better if there were more care professionals available, which is not the case currently. About the costs for the residents, that is also one of the big bottlenecks. We see that the day rate in a nursing home has to be paid, which is about 58 to 66 euros per day. And none of these costs are covered by the health insurance fund. So this this hospice care is less accessible for people who have less financial means. And then finally, 80% of the residents in the hospices have an oncological profile, and of course, other profiles should also be more eligible. So this slide actually summarizes all the bottlenecks and the added value of the hospices. But I wanted to end with some recommendations for policy, practice, and research. First of all, it would be important, if we want to expand these initiatives, it's important that these initiatives are being recognized and financed by the government, and that these initiatives also become accessible for people who have less financial means. As for practice, it's also important to spread the word so people find their way to these hospices, and that care professionals also do not solely focus on these oncological profiles. And finally, for researchers, it's important for these initiatives to be implemented on a larger scale, so we can also evaluate these initiatives on a larger scale. And it's also important to also identify the perspectives of the residents, because now we did research with the care professionals and the relatives, but of course, the perspective of the resident or the patient is also very important. So here you can find some references. If you like to contact us, these are our contact details. And I don't know if there's still time for questions. Oh, still? 2 minutes. Oh, wow.
Minutes, very well. Okay. So, any questions? Apparently, I was all very clear. All right, thank you.
Thank you very much.
Go to the next speaker, who is also a PhD researcher at the End of Life Care Group. It is Sabet Van Steenbergen. Here she is. And she's going to talk to us about a training program she is developing to support community-based volunteers around palliative care.
Okay. Thank you for the introduction. So, first of all, I would like to give some background information about volunteers. When I'm talking about volunteers, I'm referring to community home care volunteers who visit palliative residents at their home setting. We can see the volunteers as important partners in palliative care due to their approachable nature, also because of their long-term presence, and they also have sometimes experience with palliative care, death or dying. They mainly offer psychological and social care, and they fulfill a signposting role between the patient and the healthcare professionals. They also represent a bridging function between the community and socially isolated patients, and a bridge between the local communities and care services. Research has shown that there is a large but underused potential of those community-based volunteers because they receive little training about palliative care, but they are confronted with palliative care needs, and sometimes they perform palliative care tasks even when they do not know that they are doing it. So there's like a large gap between task performers and training. The community-based volunteers often notice palliative care needs that family caregivers and healthcare professionals miss. And in order to fulfill their signposting role, it's important that they should have specific knowledge about palliative care needs and about community resources. And it's important that they have good skills like relational skills, communication skills, and observational skills. And these skills and knowledge could be enhanced through training. If we go to the aim of the study, it was the study focuses on 4 goals. So first of all, we wanted to explore the desired and required knowledge and skills relating to recognizing, describing, responding to, and addressing palliative care needs with community residents and also with healthcare professionals. We would like to examine the role of the community-based volunteers. We would like to explore the communication and information sharing between volunteers and between the community and between healthcare professionals. And on the other hand, we would like to determine the learning outcomes and the development of a training program. So we used a qualitative research design in which focus groups and in-depth interviews were conducted. We did 7 focus groups, 3 with community volunteers, 3 with healthcare professionals, and 1 was mixed. And we mainly focused on the content of the volunteer role, also the communication and information sharing between the volunteers and the healthcare professionals, then the needs that the volunteers had, and the in-depth interviews were with community residents and with informal caregivers, and we mainly focused on their illness trajectory, what the volunteer meant to them, and also the communication between the volunteer and the healthcare professional. Then we use thematic analysis to analyze the data, and we also use this data to determine the learning outcomes for the training. The content and the structure of the training was developed in collaboration with a psychologist trainer, also with community volunteers and with some stakeholders, stakeholder organizations, and they all could give feedback on the content of the training, also the exercises that were used, the workbook that we made. It was all meant for the volunteers. If we look into the results, we found that it was important that they had knowledge about palliative care needs, so the social, psychological, emotional, spiritual, but it's also important that they have knowledge about the community resources around the volunteer, around the community residents with palliative care needs. And on the other hand, like I said before, it's important that they have like observational skills. It's important that they see changes in the physical environment, that they have attention to details. When it comes to relational skills, it's important that they are being present, that they respond empathically to the resident, that they are able to relate to where the resident is going through. And when it comes to communication skills, it's more about an open attitude, active listening. When we look into communication and information sharing, most of the time the volunteer and the healthcare professionals did not meet, so they did not know anything about each other's existence. So there was little to none communication or information sharing. So we developed a training program, and it consists out of 2 parts. We have a full day workshop, and we have a follow-up moment. So first of all, the workshop it's a full day. It's 7.5 hours with a lunch break included, and we used methods like case discussions, reflection exercises, and role plays, because we found it very important that it's interactive and that the volunteers who were participating, that they could share experiences and thoughts with each other. So the workshop mainly is focusing on increasing the awareness of and knowledge of the volunteer role, also knowledge about palliative care and palliative care needs, and the community resources, communication to the community resident, and communication to healthcare professionals. This is the workbook that we have made for the volunteers who are participating in the research, in the training. So all different subjects that are handled during the training, they can find it back in the workbook. So when they are doing their volunteering job, they can take a look back at it. These are 2 examples of exercises. So one of the exercises is like a social map of the community residents. So the volunteer has to think about the different actors around the community resident, and then they have to think about what actors do I already know. Should it be interesting to have contact with them? And on the other hand, we made a flyer that should make it more easy to present themselves to healthcare professionals. So it's about what I'm doing as a volunteer, what can I mean to you as a healthcare professional, and there's also place to fill in their contact details. But they are free to do what they want to do with it, but it's more like a guideline that they can use. This is like a picture of the workshop that took place in Gent. The average age is mostly 70 years old. So it's. Then we also have a follow-up moment. That's a half day, and it's 2 months later. We also use case discussions and reflection exercises. But they also can ask questions to each other, what they've lived through the past 2 months, so they can ask it to each other. So the content is more about sharing experiences, sharing knowledge, and also think about what the workshop has already meant to them in their volunteering job since then. To conclude, I think that the training is developed to meet the identified needs of volunteers, and it tries to strengthen the volunteers in their signposting role. If you look into the preliminary insights based on the feedback of participants, most participants found the workshop and the training program very interesting and very meaningful, but it was also very intensive. I think the average age is more like 70, or the age is higher, so they found it difficult to focus like a full day on all the content. The training meets the needs more of the volunteers that have little or no specific knowledge when it comes to palliative care. By following the training, there is like a growing awareness that they provide palliative care. Most volunteers did not know it before. And also by following the workshop, most volunteers try to make their presence known to the healthcare professionals after following the first day of the workshop. So the training program was tested in the period of fall 2022 and spring 2023, but now we are coming to another phase of the research, and we will evaluate the training program, and it will be evaluated on preliminary effectiveness, on acceptability, and on feasibility. So that's also one future challenge, that you will evaluate a training program on those 3 factors. We also would like to develop a train-the-trainer program that it can be implemented in organizations that work with community-based volunteers. And then also another future challenge is more about the shrinking population of volunteers, and it's very difficult to motivate them to follow training programs like this. Also, when we are organizing the training programs, the population who followed it, we had like very small groups, and it's very difficult to motivate them to come 2 days as well. So that was it.
Thank you, Sabet. Any questions in the public?
Okay, thank you. Very fine presentation. A shrinking pool of volunteers. My question is inspired, but what was to see behind you? There's a street, and this is one of the most diverse streets of Antwerp, with more than 180 different nationalities, cultures, religions, everything. And I think that's one of the things. I'm a GP here in the region, and I know that those people who are walking there have no notion about palliative care, have no notion about palliation, have only notion about hospital curative care. Yeah? And that's why, and I think there's still a lot of job to do to include those persons to the way we here, mostly white people, think things should go.
Yeah, it's also a future challenge, I think. Yeah, and it also, when I look to the participants of the workshop, they were also they were all white, but it's also because of the organizations where we worked with, the volunteers they are also more like white people, but I think it's a future challenge to implement it and to think about how we can include those people as well. But
are there any experiences from abroad, including other cultures within palliative care in a large way, but then also in volunteering in palliative care? Anybody has any experiences in how to include other cultures? Yeah, wait for the microphone. Yeah.
Well, I did not research this myself, but I work with people who try to be inclusive, mostly in the terms of geloof, religion. Yeah, and you really need to try to involve ambassadors, or you need to have people who have a certain religion to be an ambassador, to understand what palliative care is, and they need to speak in their own language with the community they're part of. So my keyword is ambassador, and try to reach ambassadors.
All right, thank you for sharing that experience. Anybody else who wants to comment on that, or who has another question? If not, no, then we can go to the next speaker, who is... we do, yes.
Because I know that here in Antwerp we have MOPA, it's Muslim and Palliative Care Organization, so they really try to cooperate with the regular palliative care, with the regular care, but translate it not only to the language, but in palliative care we talk a lot about religion and spiritual care, but if it's a religion that we don't understand, then we don't accept so much. So they really try to translate it, and now in a course that you're teaching for reference nurses, there's also a nurse, Habiba, and she's trying to set this up in Ghent, and she also says it's not the language, it's really being able in her religion, and for her it's Muslim religion too, to be well taught in the religion too, so she can bridge the gap.
Mm-hmm. Yeah, so it's about understanding the other religion, the other culture, and being part of it actually, and being able to translate from one culture to another. Yeah, okay, thank you. Another experience?
Well, it's also about the know-like-trust factor I talked about. When you take as an example the participation of citizens in the zorggraden from the primary care zones. We had the example this morning of the, how did you call them? Burgerplatform, civil platform. Mm-hmm. There's cultural differences. And what we try to do is like taking people from a different culture into our group. Mm-hmm. And that's not easy. It's much more easy when we become the minority and go to the other group and adapt to their culture and build a know-like trust factor like that way. And that's what the civil platform in Vlaamse Ardennen shows. It works much better than bringing people into the zorgraad, into our culture. Mm-hmm. That's a small testimonial.
Yeah, okay, thank you. Then we'll let Sabet go and we'll give the platform to John Garrett, who is actually also talking about another culture, which is the IT the information specialist, sorry, not IT, but information specialist from Digital Health and Care in Wales. He worked with them and clinical leaders in palliative care to actually collect the data and put them in a dashboard, etc. So I'm very curious to hear what you've been doing. Thank you.
Thank you very much. Oh, thank you. Yeah, so it's been a lovely session about compassion so far, and I'm going to bring sort of cold data analysis. So I do apologise at the end of the session. So I'm Gareth John. I'm the Head of Information Delivery in Digital Health and Care Wales, or DHCW. Today's talk is creative collaboration from hackathon to a last year of life population dashboard. And I'm going to be joined by Anthony Byrne, who's a palliative care consultant. And he's not in the room, unfortunately, but he has recorded a few video clips for us. But I thought I'd give you a bit of background first before we dive in to the meat of the talk. So DHCW is part of the NHS in Wales. You don't need to read all that. That's it's just we do a lot. That's what it's trying to convey. A summary version is we provide sort of new digital solutions in areas such as cancer, nursing, hospital pharmacy, and community care. We deliver apps for Welsh people to manage their own healthcare. And we provide information to improve the delivery of health and care services. And this is the area I work in. And I lead a team within DHCW which acquires, curates, and analyses the data, which is housed within our data warehouse. And there it is. So you see a number of data sets in there and sort of high-level summary. So you start from cradle to grave. You've got your maternity, child health, moving across hospital activity data sets, primary, community, and pre-hospital services. We've got some clinical data sets, including end of life. So we've got in there patient interactions with specialist palliative care services, working down diagnostics, demographics, including there is a national patient register, and then we've got death notifications. So that's the intro done, very quick intro. We've gone to the main part of the presentation, and Anthony's going to give us an introduction to the hackathon event that we attended back in May 2022.
I'm a palliative care consultant in Cardiff and the Vale University Health Board, and I'm delighted to share my experience of working with the team at Digital Healthcare Wales and the collaborative journey that we've been on towards the development of a population dashboard for the last year of life. This project actually started as a hackathon supported by the Welsh Modelling Collaborative back in May of 2022. And I was fortunate enough to be invited along as a problem owner, along with my colleague Dr. Idris Baker, who is the National Clinical Lead for Palliative and End-of-Life Care in Wales. And at this virtual event, we were given the opportunity to interact with analytical and information specialist colleagues from DHCW. And the reason for doing that was we wanted to explore opportunities to better understand what was happening to the palliative care population, particularly their needs in the last year of life. And this has been a long-held ambition for specialist palliative care community in particular, because we had very little understanding of what was happening to our patients in that last year of life and the sorts of interactions that they were having with different services and the systems of care that were wrapped around them. But we really struggled to put together data about the type of care being received by individuals, and particularly the types of services and organisational interactions that were happening, and particularly from outside the specialist palliative care field, so that we were getting an understanding of the population as a whole, and not just those that were known to specialist palliative care teams. And given those difficulties, I guess it's not a surprise that we went into the hackathon not overly optimistic about the types of data that might be available. And so our sense of expectation really wasn't very high at that point. But what was clear to us from the outset was that the analysts and the information specialists had already done a huge amount of work. They'd done some background digging into the data sets that might be available based on the problem that we presented to them ahead of the meeting. And it was very clear that we were kicking off an iterative creative process and that we weren't starting, if you like, with a blank piece of paper or some sort of specification form. Instead, as I say, it was very iterative, and we were shown examples of what could be done in terms of the data and the analysis, and particularly as well, very importantly, the visualization of that data. And we were provided with some information as we went through the morning, and then we were able to give a steer as to the ideas that we liked, the information that we thought would be useful to clinical and managerial colleagues, so that that could be developed further.
So the ideas we sort of pitched to Anneleen and the team were mainly recycled from other work we've done, and we just adapted it. So there were some analyses and visuals, and we just tailored it really to the sort of end-of-life care context. And this was quite good because it was a virtual hackathon, so it was quite difficult to break the ice. What this is sort of engaged people immediately. There was something to see and comment on, and they could see the breadth of data that was available and how it could be used potentially, and sort of encourage them then to have discussion and come forward with their own suggestions and ideas. And you know, discussions were so good. Quickly, we'd sort of agreed objectives, what would be the 2 days of the hackathon, and then the information specialists could crack on, do their analytical work, development work. Clinicians could return to their clinical work if they wanted to. So the challenge we set for ourselves was to create a cohort of individuals who died in the calendar year of 2021, and then bring together all the available data relating to those individuals for their last year of life. And we mainly focused on unscheduled care interactions. And then the idea was to analyse, summarise, visualise that data in a way that was understandable and engaging, and in a way that the users could interact that data and come up with their own insights. So we used the Office for National Statistics, or ONS, death registrations data to derive our cohort of people who died in 2021. We did exclude those who died from so-called external causes, such as accidents or suicides, because that was sort of outside of the scope of what we were interested in. And that left us with nearly 34,000 individuals in our cohort. In terms of the data sources, we had it from the Welsh Ambulance, so the emergency, what we call the 999 calls, emergency department attendances, admitted patient care, GP out-of-hours services, the 111 service, which is non-emergency calls, specialist palliative care contacts, and the Welsh Demographic Service, which is our national patient register. We did the tool we use. I'm not sure people are familiar with the BI tool, Power BI. So there's existing skills in the team. We also had existing templates, visuals, design, navigation, so that was easy. And it offered the interactivity to users that we needed. And probably the main template we sort of pitched was what we call our patient on a page. This is originally developed for a different stakeholder, actually, in unscheduled care. And it provides a sort of at-a-glance view of all the different encounters that a person's had. And in this case, in their last year of life. So each row here is an individual from our cohort. The x-axis counts down from 365 days prior to death to the death date. So the death date is the red bar. All the other colours represent interaction with different services. And the long blue bars are basically a period of a stay in hospital, a long stay in hospital. And we found that this page really engaged people. They started asking questions. The other functionality when you've got a live tool is you can hover over those interactions and it'll pop and describe what that event, what was the diagnosis, why were they there. So it really engaged them, and it was a good way of sort of eliciting further questions from the problem owners, and we were able to develop some new measures on the back of that. So here we looked at the total number of days that our cohort spent in a hospital or an ambulance during their last year of life. And you can see how the intensity increased as you get closer to the date of death, as another speaker has mentioned. We also use a national patient register to create a control group. That control group had individuals who were still alive at the end of 2021, but we'd controlled so the age and sex distribution of those were broadly similar to the cohort group. And then what we found is our cohort group spent on average 12 times as many days in hospital or ambulance than the control group, and 25 times as many days in the last 3 months of life. In terms of our reflections, we were pleased what we were able to achieve in just 2 days. There was lots of enthusiasm and engagement for both the information and the clinical side. We felt that we were equal partners in the creative process, and that's testament to Anthony and Idris. They were very open to our ideas, and sometimes it can be quite, when you've got clinicians, they can want to dominate and say, I want this, but it wasn't like that at all. It was both sides. So I thought it was quite a nice template for how, as information specialists, we can engage with healthcare professionals. Sometimes it's very difficult to get into that space. And this is Anthony's reflections.
And at the end of the 2 days, myself and Idris were astounded at the amount of data that was actually available. It really went beyond what we could have possibly expected. And as importantly, the degree to which the analytics team were able to pull that data together in ways that were really engaging and innovative. Meaning for the first time, not only did we have a different range of service interactions that we could see in a huge amount of data, but that it was presented in a way that we understood how those interactions clustered together, and particularly how they clustered together towards those last weeks of life. And it certainly opened our eyes to the tremendous opportunities there are for collaboration within the NHS, and to do something that's different and innovative. And it allowed us to feel that the hackathon work had been so successful that there was a real opportunity for us to take something forward to operationalize, if you like, in a way that would be powerful and useful, not just for the Palliative and End-of-Life Care Board in Wales, but for all people dealing with people in the last years of life, and that we could have a sustainable platform that would be used on an ongoing basis.
And so, to put it on a more operational footing, we first approached the Welsh Value and Health Centre. So they're a programme which already funds a number of clinically themed reports and dashboards. And the end-of-life dashboard seemed to fit the bill, quite nice, a really good fit. So after an initial meeting, it was agreed that they'd take on this work into their programme. And so in the Anthony's final video clip with the lovely little animations, he'll talk through the process of getting from hackathon to dashboard launch.
We were massively grateful to the support we received from the Value and Health Centre, and particularly Sarah Pontoni and her team, without which this work really wouldn't have been possible in terms of bringing it from the hackathon through to the establishment of a usable and interactive dashboard. And it reflects the truly fantastic collaborative effort on behalf of Specialist Palliative Care in Wales, particularly my colleagues in Cardiff and the Vrije Universiteit Health Board, and the fantastic team at DHCW, including Gareth John, Sally Cox, Victoria Venikova, and Catherine Roberts. And I want to also thank very much Joan Mower, the National Clinical Lead for Unscheduled Care, whose insights into the deliverables, if you like, and the sorts of interactions that we should be interrogating was absolutely invaluable. And it's a testimony to all of the team and the work that was done that we were very able to quickly get to the point of developing and launching a phase 1 population dashboard for service interactions in the last year of life. And we officially launched that in February 2023 in an online event which had about 50 stakeholders present at the launch, but a huge amount of interest and collaborative interaction in the aftermath of that launch. And we've used the information within the dashboard already to understand some of the challenges that lie ahead in terms of how it can shape and mould our ambitions as a service, but also as a programme board for palliative and end-of-life care going forward.
And so just finally the next steps. There's a bit of work to refine the data, get some feedback from the users, do some sense checking and data quality work. And also there's a few obvious data gaps, so GP in-hours contacts is always a bit of a challenge. We want to also collect patient safety and patient experience measures. We're going to expand the dashboard access to other clinical teams, and there's talk about trying to use it closer to direct care. And there's also a lot of interest from clinicians and service leads to develop that dashboard further to support new and existing programmes and services. So the Welsh Government led 6 Goals programme, which is about providing the right care in the right place at the first attempt. And I think that's part of the spirit, trying to look at how these services interact. Is it coordinated or is it chaotic? And I think it's probably a bit of both. We're also applying for funding to carry out a prospective study, and that'll involve acquiring and analysing new data potentially and try to answer new questions such as, do patients understand the system? What cluster of interactions seem to work best? What are the barriers to access? And maybe look at areas such as social cohesion, family impact, etc. So thank you very much for listening. Thanks to some of my video editors, and this content is from me and the team there. Thank you. Cheers.
Thank you very much. Just in time. Any questions from out of the room? Digitally, I don't see any questions for you, but perhaps there are questions from the people in the room. I have a question. Do you have all these data on a Welsh level, or do you also have data for smaller regions?
It's Welsh level and also regional to Wales. Yeah, but it's a national data, but we can
split it up.
Split it out as we want.
Okay. Yeah.
So like GP clusters.
And so it has just been launched, but do you already have some effects of certain clinicians doing things with it?
Some of the other dashboards that have been launched under the sort of domain of the value in health, like orthopedics, that is seeing, it's at a level of maturity where, level of maturity where we've got champions there, clinician champions, who are sort of sharing the message and looking at sort of where there are suboptimal care, like for example in hip procedures, that sort of thing, and huge variability across Wales. So it's been used in that context to sort of apply a bit of peer pressure in some cases. So I think a lot of this is they've never seen these interactions before, so they've never really seen what the system looks like. And obviously there's still gaps.
And it's just by reusing data, I understand. It's not creating new data, so that's really interesting. This is existing
data, yes. Yep. And something we knocked up literally was within an afternoon. We got a basis there and just tidied it up in a day.
That's amazing. Yeah. Any questions from the public? No? Yes. There are questions now.
Hello, John. Thank you for your amazing presentation. I'm Dr. Thomas Boeks. I'm the director of the primary care team here in Flanders. I'm very interested, of course, in our reform of the palliative care in measuring the impact and the data and also the indicators that you have used. And I was wondering that you could describe very quickly how do you get to that kind of indicators and what's the methodology after it and the rationale to select them, because that's for me very important in our future trajectory.
And I think it's always a balance of trying to come up with something you can produce from the data you've got. Obviously the data's not perfect, it's not complete, but I think that was something tangible because sort of fairly uniquely, certainly within the UK, that we've managed to link in our ambulance data to our hospital data, because it's not that straightforward. So we thought, well, let's make use of that. So there were sort of offerings we had. We'd done some linkage work in the unscheduled care world, which we could just take this directly to last year life. And Anthony thought this was actually quite a useful proxy of, and particularly, not necessarily the numbers themselves, but how regionally across Wales, what does that look like? So is it 25 times in one area or 12 times? And is it, so that's the sort of interest. And I think a lot of the value is focused on those variations and trying to sort of follow the best of breed, if you like. See, well, what is that? What can I learn from that health board in terms of what they're doing? Because they're sort of proxy measures. They're just some sort of indication of something. And maybe a system that's not coordinated, perhaps, or could be coordinated better.
I think there was another question in the room. Yep. The second row. And then we'll leave you all for coffee, because I think everybody's tired.
Apologies, you might have already covered this and I missed it, but who has access to the dashboard to see the data?
At the moment, it's a little bit of a closed shop, so we're leaving Anthony and his colleagues to basically spread that. So, we'll get requests through that purpose. So at the moment, it's growing. It is expanding, but with the Power BI, we have the ability to sort of limit access based on their sort of NHS accounts. So that's how the way it's working at the moment. But the idea is it could become more open. It shouldn't just be for it's relevant outside of palliative as well, isn't it? So, yeah. But we're leaving almost the clinical champions sort of pave that way. We'll do the analysis and we'll do the pretty pictures and some pretty pictures.
All right.
Maybe not the animations. We won't do that. Yeah, we'll leave that to somebody else.
All right. Thank you very much. And I'll leave you all for coffee and tea. Thank you.
Cheers.